Good evening and welcome to STEM India meeting this year. And my topic today is pharmacoinvasive therapy as good as primary PCI? This is a lovely slide which a friend of mine, Bernard Gersh, wrote in the JAMA in 2005, which shows very clearly that as you go later in the cycle of chest pain, the benefit that you accrue is going to be lower. For example, if you move from point C to D, which is a 60 minutes earlier intervention, whatever type of reperfusion you may be, you get a 30% reduction of mortality. While you go from, say, A to B, which is a 240 minutes reduction, you get only a 10% benefit. So clearly, the time from symptom onset to reperfusion therapy is the most important thing, and that's what we're talking about, the golden hour. Now, what about in India? Primary PCI has seen an uptake, but you can see clearly that we have about, in 2017, about 53,000 patients who undergo primary PCI, which represent about 13% of the whole PCI. But if you look at 2.5 million patients with STEMI, clearly the amount of primary PCI being done is less than 10%. So we are looking at a strategy which is called as pharmacoinvasive management, which means a strategy of routine or adjunctive PCI between 3 to 24 hours after lysis in patients with ST segment elevation or STEMI. And this is because we need to look at an alternative therapy for patients who cannot get a primary PCI. So is it as good? So what we did was the first study, which was a STEPMI study, which was an Indian-based study with a primary objective to assess the efficacy of prompt fibrinolysis coupled with contemporary antiplatelet and antithrombotic therapy at first medical contact, followed by timely catheterization or rescue in STEMI patients within 12 hours of symptoms, versus a strategy of standard primary PCI. And the secondary objective was to assess safety during the course of the study by means of monitoring emergent adverse events. So we had 5 hospitals from south of India, and I was the lead for the study. And we had 2 groups, A and B. The B was primary PCI, just like usual. And the group A was tenecteplase, followed by a pharmacoinvasive strategy. And this also included a rescue PCI. The endpoints were at 30 days, a composite of death, reinfarction, repeat revascularization, congestive heart failure, and the secondary endpoint was STEMI major bleeding. And what was interesting is that A was a pharmacoinvasive group and the B was a primary PCI. And you can see that many of the patients who got lysed, at least 7% of them had no lesions seen on angiography, typical plaque erosions which disappeared after you lyse the thrombus off. Also, the open artery, even after the 4-hour median of delay for a pharmacoinvasive procedure following the onset of chest pain, 82% of patients with tenecteplase had an open vessel. The more important thing at the time of the procedure, and the thrombus content was much lower, unlike primary PCI where you get a very high thrombus content. So clearly your lysis gives you a time frame for an open vessel. It also reduces your thrombus. The TIMI flows before the procedure were better in the tenecteplase followed by the pharmacoinvasive as compared to the primary PCI. And what was most interesting was there was no significant increase of bleeding. And that was predominantly because we had a younger group of patients and there was a radial access which was more popular in the patients undergoing a pharmacoinvasive therapy, which reduced bleeding at the site. This was published in the Open Heart by us and followed by a 2-year follow-up data in Indian Heart Journal, which suggested the same outcomes at the primary PCI and pharmacoinvasive. Though this was not a large randomized study, it showed that clearly the outcomes were the same. This was followed immediately by the big publication in the NEJM of the stream for patients with STEMI who underwent a primary PCI versus pharmacoinvasive, who could not take primary PCI in 1 hour of contact. And after the initial increased bleeding, after reducing the tenecteplase to half dose, we found that numerically, the fibrinolysis followed by pharmacoinvasive was possibly numerically better, but p-value is not significant. So our conclusions of STEPMI was the same as what we saw with STREAM, and that pharmacoinvasive is associated more than 80% in fact-related artery patency, and the significant patients did not require any procedure or stenting, and it alleviates the logistic or geographical barriers of primary PCI in India. Now, we started the Tamil Nadu STEMI project following that with, again, the 2 strategies, a primary PCI in those with short transportation times and pharmacoinvasive in those with lung transplant. The initial protocol was in the BMJ, and the enrollment and data was finally published in the JAMA Cardiology. We had a pre-post enrollment strategy, a system of care after 3 months of enrollment, where the primary procedures were done according to what was going on in those hospitals concerned. We had both hubs and spokes, 4 hubs and 40 spokes in this group of patients. And what was very, very interesting is we had 900 patients in the pre-infiltration and 1,500 patients in the post. And streptokinase was the commonest thrombolytic used. What it shows was thrombolysis, once you put the system together, was well treated in patients in the hospital with 31 minutes as the median for giving streptokinase. So basically, people will access a smaller hospital faster. What about MACE events? If you did pharmacoinvasive or primary PCA, they were comparable, but thrombolytic and no treatment, which was a substantial group of patients in the study, the outcomes were poor. The impact of a system was also very well seen, that if you did a system of care pre-post, even with streptokinase, your infarct-related artery patency was very good, almost 86%. The thrombus burdens came down, readmissions came down, and the target vessel revascularization decreased. Now, is this a sort of strategy only for poor countries? Answer is no. This is South Korean data from the SERV cardiovascular intervention, which you know that South Korea has got a very aggressive primary PCI program. And you can see that STF segment elevation receiving pharmacology compared to primary PCI, shorter time to reperfusion, higher culprit vessel patency, and similar 12 months data. Same data published in the JACC interventions from Canada, showing that the pharmacoinvasive was as good as primary PCI. So the choice is not the reperfusion strategy. The important thing is how quickly you do it. 40 to 75% of patients, even in the best European nations, cannot be treated within the door to balloon times or of 90 minutes to 120 minutes. So almost half the patients don't get the reperfusion correctly. This was the first data from China, which showed superiority of a half-dose alteplase followed by pharmacoinvasive versus primary angioplasty. And you can see that both the myocardial infarction flow, the TIMI flows, and the ST segment resolutions were better in the pharmacoinvasive arm than the primary PCI arm. This is the largest data from the FAST-MI study, which is an all French study over 5 years' times. And the most important takeaway here is there were 3 groups of patients, one who got timely PCI, one who got late PCI, which is 28%, and another group, 28%, who had pharmacoinvasive strategy. And a substantial portion of the primary PCI was beyond the timelines of 120 minutes. And as foreseen, those patients have poorer outcomes as compared to the primary PCI within the window and pharmacoinvasive strategy. So primary PCI and the indistinct 120 time limit was rightly reviewed by Franz and Peter Sanem in this article, and basically saying that we need to be clear that it is not the question of what is the type of reperfusion, but it is the time to reperfusion which is important. What are the issues in STEMI care today? Is half-dose thrombolytic right for all pharmacoinvasive patients or only the older? Is concomitant anticoagulant therapy effectiver than clopidogrel? And is it as safe when used with fibrinolysis? What is the optimal window for invasive assessment in a pharmacoinvasive strategy? What is the concomitant non-culprit vessel intervention strategy? How do we better address failure of microperfusion and after reperfusion therapy? And this is very important. And the most important, what communities interventions work best across international borders to enhance effective pre-hospital utilization. So I'll conclude with saying that pharmacoinvasive is as good as primary PCI, at least in most of the population, which is low risk, which is 95% of STEMI. It widens the time window for coronary angiography, logistically easier to accomplish, especially during off-office hours, an ideal strategy in India where the transportation times can be long and cath labs are located in metros. I think primary PCI may be superior in high-risk AMI patients or patients who cannot undergo primary PCI within 120 minutes of the first medical contact. So that's my conclusion, and I hope I've convinced you that pharmacoinvasive strategy is as good as primary PCI in most patients, and the most important thing is to get to an early reperfusion. Thank you very much for your patience.